Hello, can you all hear me?
Yes, ma'am.
Okay, perfect. So, thank you so much for coming and for attending our third session in um, what do you call this? Psychiatric or mental health nursing. And to continue with our lecture from where we left off yesterday, we are now in the neurodevelopmental disorder of the topic. Okay, so are you guys ready to begin?
Yes, ma'am.
Okay, perfect. All right. So first, we're going to talk about in your neurodevelopmental disorders. We actually have two disorders. This is your autism spectrum disorder, and we have your ADHD. So first, let's talk about your autism spectrum disorder. Now, this is a problem wherein the child actually has, a complex and persistent deficit in social communication and social interaction. All right. So their problem is in social communication and social interaction. They cannot establish communication with their parents, with their friends, unlike any other toddlers who are, interactive. It gives us so much joy if you have, a child with you at a toddler age. But in a child that is diagnosed with autism spectrum disorder, they have a persistent deficit in social communication and social interaction. Now, they are usually restricted, stereotype pattern of behavior. Now, if you may wonder as a parent, what is the exact cause? So while my child develops spectrum or autism spectrum disorder, well, until this recent days, still the exact cause is unknown. All right. So, and these symptoms are usually noticed by the parents at 3 years of age, because at this age, the toddlers would, are very like interactive with their parents. They have this separation anxiety that, whenever the parents leave, their child would cry. But in a child with autism spectrum disorder, since they cannot establish that connection, they do not have that separation anxiety. Whenever their parents leave, they'll just like be on their own. Or whenever they are hurt, they cannot really express their emotions. So the problem or the main problem in your clients with spectrum autism spectrum disorder is impaired interpersonal functioning. All right, impaired interpersonal functioning. So, what are other manifestations that we have to look out for in a child with autism spectrum disorder? So, they have an abnormal or lack of social play. Abnormal in a sense that they are attached to an inanimate object, which is not normal for a toddler to be attached to, let's say, for example, toys, that they're so fun that they love to play with. So sometimes in a child with autism spectrum disorder, they carry along with them like books or any weird stuff that is not appropriate for their age. All right. And they do not have, or they cannot really establish social play with other friends or other toddlers. They have impairment in peer relationship, impaired and lack or abnormal speech. So they also have this repetition of words, echolalia, and monotone of voice. Okay, echolalia, again, repetition of words, and they have no imaginative play. So at this age group, toddler. So if you can remember back then, our imaginations are continuously developing. Our imaginations are very creative. So we tend to portray ourselves that, oh, I'm this superhero, I'm like her, and we do tend to have this imaginative friends as well, right? That we interact, that we think exists in our mind. But in a child with autism spectrum disorder, it's absent. All right. They are also have this persistent attachment to objects. So again, persistent attachment to objects. Why? Because it's very common for this age, for a child with, regardless if they have autism spectrum disorder, but a normal child, remember the comfort, um, or the security blanket. All right, so for this child, the security blanket for a child with autism spectrum disorder, this is kind of like the weird stuff that they carry along with them. In a normal child, we consider a security blanket, okay, that is what it could be, like um a doll, or it could be like a blanket that they cannot leave without, they cannot sleep without, or even like a clothing that they have to wear all the time. That is normal for a child, okay, in a toddler child. But again, in a client with autism spectrum disorder, they may always bring with them like an empty bottle or an empty plastic, because for them that is their security blanket. And you do not, as a parents, you do not remove that from them. You do not discourage that, because otherwise they would develop tantrums, right? Now, aside from that, they actually have this self-injurious behavior. All right, so self-injurious behavior that is evident by head banging. All right, so they have this repetitive body movement, such as what? Rocking or head banging. Most especially the head banging, because this is where their expression that they are having tantrums. All right, so these are the common manifestations of a child with autism spectrum disorder. Now, knowing that these manifestations, still our priority for this child would be what? Safety. Safety in a sense that, okay, because of their self-injurious behavior and head banging. So, and it's at the same time, they cannot really express themselves that they are already having pain. They do not, totally, like, they would cry because they're in pain. Even like when they experience pain, they cannot verbalize that, mom, it's painful, mom, I'm hurting. No, they cannot. And oftentimes, this is like um a struggle for the parents as well. So aside from maintaining safety for a child or with autism spectrum disorder, you also have to consider the emotions of the parents, okay, most especially the mothers, because it's very difficult for them to accept that the fact that their child cannot establish emotional, okay, or interpersonal relationship with them. So again, let's cite are the management. Okay, so provide a safe environment or safety for this child. Aside from that, you have to implement safety precaution for self-injurious behavior. Implement safety precaution. So for any head banging episodes, so you know that your child, you expect that, okay, that my child has an ASD. So as expected, she may have a frequent head banging episodes. So when you notice as a parent that there is already a repetitive, movement such as head banging, so that's the time that you let them wear even like a helmet. All right, so you would recommend them to wear a helmet so that every time when they bang their head, it's not gonna cause injury in their head. What else? You can like put a pillow, okay, when they are head banging. So anything safety precaution for self-injurious behavior. Now we also have to make sure to advise the parents to maintain consistency with their routine, habits, and preference. So consistency: at 8 in the morning, your child takes a bath. At 7 in the morning, your child wakes up, she eats breakfast or he eats breakfast, take a bath. So those consistency of their um everyday life. All right, avoid placing demands on the child. All right, avoid placing a demand such as what? Asking them to point or identify which one is this, what is this, can you tell me? Because as a parents, we are so fond, or you're so fond of identifying the body parts. And when the child can identify, it gives us like a proud moment as a parents, that, oh, my child, the 3-year old, is able to identify this and that. Okay, my child knows how to write at 3 years old, at a very young age. That makes the parents proud as well. But in a child with ASD, it's very important that you have to advise the parents not to place demand on these children, okay, with ASD, because otherwise that somehow would make them feel frustrated, aggravated, and even tantrums can develop. So provide support to the parents, all right? Provide support to the parents, all right? So are we clear? Clear, nurses?
Yes, ma'am.
Okay, another developmental disorder, we have your ADHD, or also known as your attention deficit hyperactive disorder. So, ADHD, from the word itself, hyperactive. The child in here is super or hyperactive. They cannot stand or they cannot sit still. They cannot like focus in one attention, and these are a behavior of a child that is characterized by inattention. What else? Impulsivity and hyperactivity. All right, so it's characterized a child with ADHD. Common characteristics that they have or a problem would be the in their attention. Okay, they have a decreased attention span. They are highly impulsive and they are hyperactive. Okay, and these ADHD, same with your ASD. This is more common in boys. All right, ASD or ADHD is more common in boys. Now, ADHD for child or toddler diagnosed with hyperactivity, that it grew a concern of a mother that it seems that my child has like 100% or more than 100% energy all throughout the day. My child cannot seem to relax, this and that. And if not managed, this can actually carry out into adulthood. Now, once it's already in adulthood, now this is now termed as your ADD. All right, attention deficit disorder. Okay, ADD, this is for adult. For children, this is your ADHD. For adult, ADD, attention deficit disorder. So for adults, still, this is more of a characteristics that you cannot seem to accomplish one task. Okay, so you have so many tasks in your mind that you cannot finish. So if you like would do something, okay, for today I'm supposed to laundry, so you go to the laundry and then all of a sudden you see a piled clothing, and then all of a sudden instead that you'll do the laundry, you go to the piled clothing, and then when you see like some old clothes that you have you no longer use, then you keep on shifting from one task to another, and most often these tasks are not completed. All right, so that is for the adult ADD. Okay, attention deficit disorder. But going back for children, we have your attention deficit hyperactivity disorder. Again, these are behavior disorder characterized by inattention of a child, impulsivity, and hyperactivity. Now, behavioral findings in a child with ADHD, again, they have poor attention span. They cannot concentrate. And whenever the teacher discuss, it seems that their mind, their attention is elsewhere. They're not focused on the teacher. They are easily distracted, all right? And because of their poor attention span, they have learning disabilities. Sometimes they do not get good grades in school, all right? And they talk a lot, all right? Excessive talking. And sometimes they can be a disturbance to their classmates, all right? Impulsiveness, they cannot take turns. They want their whatever they demand, okay, should be addressed right away. Now, they love to interrupt and intrudes on others, okay, most especially their classmates, or even in a group of, like, let's say, um, your parents. I've experienced this in the past that my parents have social gatherings with her friends, and they brought their daughters along. So there's this a friend of my mother who brings her child with her, and that child actually is diagnosed with ADHD. So while they're talking, my parents are talking, their friends of my mother is talking. So this child was distracting, the circle, distracting, and she really wanted to have that attention, so she's fond of interrupting. All right, now again, they shift from one uncompleted task to another. So this is what, okay, a behavioral finding that if not managed at early age, that can be carried on through adulthood. Okay, they have difficulty following instructions, all right, and fidgets with hands and or feet, okay, and squirms on sits, fidgets their hands, okay, with hands, because it's a way of showing them that they have a control. All right, remember, toddler autonomy. All right, now management for this, again, because they are easily destructive, they're impulsive, still safety. All right, and as a parents, you have to maintain a timeout whenever necessary. A timeout can be, okay, a simple punishment for the child. Let's say face the wall, that can be considered as a timeout. Let them relax, let them sit still or stand still. All right, structure the environment. Okay, structure the environment in the sense that in the living room, you do not rearrange the furniture. You do not, as much as possible, the furniture stays that way, because these children would love to roam around, running around, and to prevent, any possibilities of injury. So structure the environment. All right, now behavioral therapy for these children as well is recommended. And sometimes, these management are more effective, or, okay, if the child, or if the doctor, would provide, or definitely the doctors would provide the drug of choice. All right, and consistency in taking your methylphenidate Ritalin, this can actually manage the attention of the child. All right, so methylphenidate Ritalin, this is usually given twice a day, but take note, all right, this is given twice a day. First dose given before breakfast, and the second dose is given before 6 p.m. Why given before 6 p.m.? Because side effect of your Ritalin, this can actually decrease the appetite, or the sleep. All right, it decreases the sleep, or to prevent any episodes of insomnia. Okay, and again, decreases the appetite of a child. That's even though that it decreases the appetite of the child, still we give this before breakfast. Why? Because methylphenidate Ritalin, this is best absorbed on an empty stomach. So before eating, okay, before a meal, you have to let the child take it. And 30 minutes after taking it, that's the time that, okay, the child would have a breakfast. So again, first dose given before breakfast, and second dose should be given before 6 p.m. to prevent insomnia, okay, or to prevent disturbances in sleep. Remember, as much as possible for these children, okay, not to interrupt the release of the growth hormones, they should have an hour of their sleep, that at 9 p.m. my child should be on bed, or as early as 8 or 9, my child should be sleeping, and then wake up um the following day, or at around 6 or 7. Okay, so at least the child should get enough good sleep, because this is the time that the growth hormones are released. Okay, and we do not want them to have or interrupted or obtunded growth for this child. All right, so again, nursing diagnosis for these children, we have your risk for injury and impaired social interaction. Okay, any questions before we proceed with your practice exam questions? Any questions? None so far? Okay, let's try to answer this question. A 4-year-old is found to have attention deficit hyperactivity disorder, or ADHD. Which description is of the child's behavior will the nurse expect when obtaining a health history from the parents? Select all that apply. One, some, or all response may be correct. Okay. Do we have impulsiveness?
Yes, ma'am.
Yes.
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 Okay. How about excessive talking?
Yes.
Yes, ma'am.
Yes.
Good. Okay. Spitefulness and vindictiveness. Okay. What do you mean by vindictiveness? Did we
Don't
talk
know, ma'am.
about spitefulness and vindictiveness?
No.
No. Okay. Deliberate annoyance of others.
Yes.
Deliberate annoyance of others.
No.
No.
How
No,
about
ma'am.
playing video games for hours on
No.
end?
No.
Playing
No.
video games for hours on end.
No.
All right.
No.
Failure to follow through or finish tasks.
Yes.
Yes, ma'am.
Yes.
Okay. Playing video games for hours on end.
No.
No.
Okay. Why not?
Because it
They
need
can't just
attention.
stay in the same place for an hour to play a video game.
Okay. But take note, nurses, this is actually video games. This is very common at their age, right? Common. Okay.
Yes.
Games that are fun, engaging games, interactive, often maintains the focus of the child. Okay, this is something that would let them be still hyperactive in a sense that their mind, okay, is hyperactive, not only shown through their actions. Okay. Yes. All right. So answers are impulsive, excessive talking, playing video games for an hour or end, and failure to follow through or finish task. All right. Are we clear? Are we
Yes,
clear?
ma'am. Yes, ma'am.
Please, can you explain
Alright.
number 5? Explain number 5, please.
Playing video games for hours on an end. Okay. So very common for the child. All right. At their age, they are engaged or they're more fond of playing video games. Still, this applies to a child with ADHD, even though that they have a decreased attention span. But take note, this is more of a video games. Okay, this is fun, this is engaging, and this is what interactive. All right, so this would often, the more it increases, okay, their attention, focusing more on the, okay, video game. All right, so very common for a school age child, all right, or even a toddler, that it's not only like a child with ADHD that they are, fond of playing video games, even lasting for 4 hours or 5 hours if they're not interrupted at all, right? I'm I can speak to that. I can attest to that because during at my school age, I would love to like be absent from school. Why? Because I wanted to play video games. That's how they are attached to video games, which is a common, factor for a child at this age. Okay, are we clear? Clear, everyone?
Yes, ma'am.
Okay, how about the others?
Yes, ma'am.
Okay,
Yes,
so
ma'am.
okay, so inattention or decreased focus that they cannot really, pay attention to would be more of their scholastic or school related, lessons or activities. Remember, they have learning disabilities. All right, learning disabilities, it's because they cannot pay attention to a teacher that is talking or discussing. But when it comes to video games that are, that are fun in their eyes, that are sometimes, these video games are kind of like brutal, in a sense that depending on, let's say, Mobile Legends. I'm not fond of playing Mobile Legends. So if you would download Mobile Legends, it's very interactive, it's fun. They would somehow release their, their attention or being impulsive through the game or through the video games. Okay? Are we clear? Clear, nurses? Okay.
Yes, ma'am.
It seems that somebody is writing in my screen. Neha? Who is Neha? Okay. Neha, I'm seeing Neha navigating. It's not me. I cannot even erase it. Somebody is manipulating the screen. See, my checks are hello. Okay. So that explains as to why, my all of a sudden the screen moves. Okay. Anyone from Okay, do we have Nimi here? Is Nimi around? It's by mistake. Okay. I'm not even sure as to why you were able to like write down in my screen. Okay. So okay, just give me 1 second, all right? Okay, can you erase it, Niha? Because these writings are shown. I cannot erase them. These one. Can you erase it? I'm not sure as to why you were able to write down. Okay, Niha, can you erase this one?
No, ma'am, I'm not able to erase it.
But you were able to write it, right?
No, ma'am, it's by mistake. I think
I don't know what happened.
I don't know, ma'am. It's not.
Okay, there you go.
Yeah.
Okay, so onto our neurocognitive disorder, all right? Onto our neurocognitive disorder. We have your delirium, okay? Neurocognitive disorders. So we have your delirium, and we're going to talk about your dementia. So when we say delirium, all right, so this is not just common to your elderly, but okay, there is also a disturbance in cognition, memory deficit, disorientation, and perception. The difference between your dementia and your delirium is that delirium, this is just temporary. It is reversible. Anyone can have a delirium, not specifically related to age. Okay, so especially if you have an infection affecting the nervous system, such as your meningitis and encephalitis. Anyone with meningitis, encephalitis, they can actually have delirium, okay? Because meningitis, encephalitis, this is brought about by increasing intracranial pressure. What else? Okay, those with head trauma. All right, what else? Those with withdrawal syndromes, okay, or alcohol withdrawal deliriums, especially when they are on the process of detoxification, which we will talk about later on. Anyone who is alcoholic, okay, they would experience what we call the alcohol withdrawal delirium, okay, or we call this your delirium tremens, okay, which is a medical emergency for an alcoholic client undergoing detoxification. All right. So because back then when we say delirium, this is more or exclusive or only associated to your elderly, but no. Okay. So it's not just only limited to your elderly, but also those who are clients who are in the ICU, intensive care unit, those with high grade fever, they would now have delirium. And sometimes, because of their delirium, they would have disorientation. They can no longer recognize you, the caregiver. They cannot recognize or they cannot tell where they are. But as soon as, let's say high grade fever subside, and then, this would actually be just temporary. Okay. Now, delirium's clinical findings includes confusion. All right. They would tend to hallucinate or they would have illusion. Again, hallucination, this is without stimuli, right? Illusion, this is with stimuli that causes you to misinterpret that object. Whereas hallucination, okay, it can be auditory, tactile, sensory, or gustatory. All right, there's no stimulus. All right, what else? Client will also be disoriented to time, place, person, and situation. Memory defects, okay, both recent and remote. Remote means the past memory may be affected. Okay, sometimes when they are having, let's say, meningitis, one of the signs and symptoms of meningitis is what? Fever, high grade fever. And because of that infection, all right, they would now have, if you want to ask them a brief history that happened a couple days back or months back, they cannot recall it, and even up to present. All right. Slurring or rapid speech. All right. Slurring or rapid speech. What do you notice? Still, we have your tremors, agitation, and irritability. Tremors, agitation, and irritability, these are a very common manifestations for a client or an alcoholic client who is experiencing delirium tremens. But again, the good thing about your delirium, this is reversible. Okay, so since there is a cause, okay, as to why the client would experience delirium, so you have to identify or treat the cause to manage delirium. All right. So as one of our management or priority management, we have to treat the cause. Okay. So if it's related to encephalitis, manage encephalitis. If it's related to meningitis, manage meningitis. Or related to head trauma due to increasing intracranial pressure, manage that increasing intracranial pressure to prevent episodes of delirium, sudden or recent or even remote memory loss. All right. Now, as a nurse, you have to also prevent further damage because, again, they would have this agitation. Okay, they would also tend to have hallucination, and it depends on the type of hallucination that they would experience. That sometimes, these would cause harm or injury to them. All right, what else? Provide diet high in calorie, protein, and vitamins. Okay, eliminate caffeine in the diet, okay, because caffeine, this increases more of their alertness, right? So eliminate that because this can actually more predispose the client to be or would have illusions or agitation or increasing, or hyperactivity or hyperactiveness. What else? Provide a safe and quiet environment and reorient to time, place, person, and situation. Okay, that is your delirium. Again, delirium, affectation in the cognition and memory. It can be the past and present memory that is affected, but again, the good thing about it is that this is reversible and temporary. So what makes the client to have delirium? So it can be due to nervous system infection. What else? Head trauma or following a vehicular accident. What else? Alcohol detoxification process. Okay, so the alcoholic client would experience deliriums. All right, again, delirium, this is reversible. What is not reversible, nurses, would be the dementia of Alzheimer's type. Okay, dementia of Alzheimer's type, this is actually more of progressive. Once you are diagnosed with dementia, if you already have early signs of dementia, such as what? Forgetfulness, this can actually progress to a more severe type of your Alzheimer's or dementia of Alzheimer's type. Okay, so when we say dementia, there is still a cognition, deterioration, and progressive loss, okay, of the ability to carry out activities of daily living. Now, in your elderly, now this is now more common to your elderly, your dementia of Alzheimer's type. Now, these elderly would not know how to operate, let's say, they do not know how to operate a cell phone. They do not know how to operate the dials of the oven. They cannot identify that object, what is that for. They cannot even they don't know how to take a bath. They don't know how to dress themselves. They do not know, oh, I'm supposed to do this and do that. All right. That is your dementia of Alzheimer's type. And take note, this is progressive from mild to more moderate and even to a severe type of your Alzheimer's. Okay, so the client may experience a steady decline in their physical and mental functioning, and usually they require long-term care. Very common in your nursing home facility. Anyone here working in a nursing home? Anyone? Nursing home facility? Not
Yes.
yet? This can be very challenging, right, Praktisha? Do you agree with me?
Yes.
Yes, right? And very majority in the nursing home, they have what?
Dementia.
Alzheimer's, right? They have Alzheimer's. And mind you, um, it's really one of the most challenging role as a nurse if you'd be working in a nursing home. But in terms of migrating, it's a lot easier for you to migrate if you will apply in a nursing home. Challenging in a sense that it's really hard to deal or care for a client with dementia of Alzheimer's type. Okay, you would rather care for an infant or let's say toddler rather than caring for a client with Alzheimer's. Okay, I'm not like I'm not I'm not like invoking that do not be this and that. If you do have passion for caring for elderlies, then go ahead. Okay, follow that passion of yours. If you find happiness in caring for the elderlies, go ahead. It's just that truth to be told, it's way more challenging. Do you agree with me, Praktisha?
Yes, I do.
Yes, right? So anyone, would you like to share your experience? Would you like to share your experience? I had a friend before, she migrated to the United States. And again, it's easier to migrate to the United States if you will apply in the nursing home facility. So on her first few days of like, she was still having orientation, she said to me that she had a culture shock. Culture shock in a sense that in that facility, majority of them are all have Alzheimer's. And she had this experience that she experienced herself. They were like, sorry for those who are eating, but we're all nurses here, we're all professionals. Someone was like like grabbing or their bowels, their feces, you know um putting it to the other client. So that's how difficult, that's how challenging it is, because again, they do not know, they do not recognize even as simple that, oh, they are already defecating, they are removing their bowels. So but overall, it's very rewarding. Okay, so again, going back, dementia of Alzheimer's type, there is a deterioration and progressive loss of the ability to carry out activities of daily living. So it's by progression. So either oftentimes, okay, they would experience it through mild hallmark sign would be forgetfulness. All right, and sometimes, aside from forgetfulness or memory loss or amnesia, they can no longer remember. They also have this aphasia. Okay, when we say aphasia, this is a language disturbance in understanding and expressing words. Either it is receptive aphasia. Did you remember our neuro topic? Okay, we've talked about two types of aphasia. We have your receptive aphasia and your expressive aphasia, right? And not only that, a combination of your receptive and your expressive aphasia, that is what we call your global aphasia. So this is noted in an elderly, all right, with Alzheimer's. Now, they also have the inability to recognize or identify familiar objects, okay? And that is what we termed as your agnosia, okay? Agnosia. It's like agnosia, okay, with a question mark, agnosia. What is that? Okay, they do not They are not able to identify familiar objects, even like a fork. They don't know what the fork is, what's the use of the fork. All right, they do not even know how to, especially the dials or the buttons of, or the dials of the oven. Okay, let's say this is the oven, the dials, these are the dials, okay, that you would turn it on. Now, um, they do not know what is that for. They oftentimes play with this. And the problem with this is that these are oven. It has gas, right? Now, for safety purposes, if you are caring for an elderly with Alzheimer's or dementia of Alzheimer's, for safety purposes, you have to remove the dials of the oven, because otherwise, very common that they do not know what is the dial is for of the oven, and they would just turn it on, play it, and then they would forget that they turned it off, okay, or they would just leave it. And then here comes, your house will smell gas, okay, and then the more it predisposes the risk for what, okay, burns or fire. Another thing, okay, they have the inability to perform activities despite the intact motor function. Inability to perform activities. So what are those activities? Such as, it's time for you to take a bath, okay, it's time for you to eat. All right, they do not know. They do not know, oh, this is the way you take a bath, most especially if it's already a severe type of your dementia of Alzheimer's. Please take note of these 4 A's, as these are, okay, if you will be asked a SATA in your exam. All right, we have your amnesia, aphasia, agnosia, and your apraxia. Okay, again, slow deterioration. It actually goes through a stage when you are diagnosed with dementia. Be alarmed that, okay, you often forget things. You forget your, let's say, anniversary. You forget your, that you have a deadline to meet. You forget where did you put the keys. You forget where did you put your cell phone. You forget that where you put your glasses. You don't know, but you're just wearing it all throughout the day, and here you are looking all over the place for your glasses. You're looking all over the place with your car keys, okay, with forgetfulness. And this is actually the hallmark sign that, okay, predisposes an elderly to have Alzheimer's. Now, sometimes, they would forget their date of birth. Okay, they don't know that today, oh, today is my birthday. They don't know, they forget. Okay, that's how worse their memory loss is. All right, so moderate, this is the time when they're always confused about things. Okay, that's the time that they would have or exhibit that agnosia. They're confused about, oh, what is this for, what is this and that and that. All right, and severe, when it's already a severe, there is already deterioration in all areas of function. Deterioration in all areas of function, just like what I gave to you as an example earlier. All right, so their memory, their cognition, it's no longer, uh, you know um it's really worse. All right, now, to manage these clients, again, safety is our priority for your clients with dementia. What else? You have to make sure to remind them, reinforce them of the retained skills, because we don't want them to be more dependent of the nurses. Remember, they still have an intact motor function. It's just that you have to keep on reminding them that, oh, this is plate, this is spoon, this is fork, this is how you eat, this is the bathroom, this is the way to the bathroom. And most of the time, they would place a marker on the floor, way to the bathroom, okay, that they will guide, that they will follow. Okay, now what else? Provide continuity of care, consistency of care, orient them to time, place, and person. All right, emotional support to the family as well. Why? Because it's not easy to take care for your grandparents, with Alzheimer's. It's not easy, and sometimes they would have this caregiver burnout. They feel exhausted because most of their time, instead that they are working, they do what? They care for their families, most especially for those who do not afford, okay, or they cannot afford to put their parents in a nursing home or nursing facility. Okay, so emotional support to the family. Now, they also have these episodes of wandering, okay, or wandering, we call that your sundowning phenomenon. Sundowning phenomenon is that there is increasing wandering. They leave their house, they leave their the facility and then go elsewhere. The problem with that is that, remember, they do not know the direction. Okay, they do not know where to go, or they cannot identify directions. So, okay, um especially at the late in the afternoon, they have that episodes of wandering, leaving the facility. All right, it's like, sometimes, they would think that, oh, I have to go to this certain place, I have to, they have that, they want that to, like, oh, I used to go to this place before, you know and again, the problem with that is that they do not know directions. All right, so in episodes of wandering, or what we call your sundowning phenomenon, okay, to provide safety, again, you have to close and secure the doors in the facility or in the house. Okay, even make sure that the gates are locked. All right, use identification bracelet, that in the event that they wander, it's a lot easier for you to, the let's say, the police, that they would be able to identify this elderly on the street walking. And electronic surveillance. All right, electronic surveillance, or the CCTVs. Okay, because this will definitely identify the whereabouts of your elderly. And sometimes, the bracelet, this actually has like a GPS that would be able to track your grandparents or elderlies with dementia of Alzheimer's type. Okay, are we clear? Any questions? Any questions? Okay, let's try to answer this one. Practice question. All right. Which sign and symptoms denotes the presence of dementia of Alzheimer's type? Oh, it already showed. Okay. Which of the signs and symptoms denotes the presence of dementia of Alzheimer's type? Okay. When we say ambivalence, this is not being sure about your emotions. Okay. So we have your forgetfulness, flight of ideas. Do they have flight of ideas? Not much. All right. Or they do not have flight of ideas. Loss of association. Not. Okay. And your expressive aphasia. Remember the 4 A's, right? Because it already showed the answer earlier, but I'm pretty sure you'd be able to answer this one. Okay, now what else? So a home health nurse providing care for a 79-year-old male client diagnosed with Alzheimer's disease in assessing the home environment. The daughter, who is the primary caregiver, shares that she is getting depressed. Take note, the daughter, who is the primary caregiver, shares that she is getting depressed and misses her own personal social life. Which responses by the nurse indicate appropriate nursing intervention in this situation? Select all that apply. Okay. Would you answer number one, suggesting she join the Alzheimer's support groups? Number two, praising her for doing the right thing for her father. Number three, educating her the signs and symptoms of depression. Number four, exploring with her ways to interact with friends and family more. Number five, explaining her that her feelings of loneliness are normal and would pass. Number six, identifying what aspect of caring her father causes her to feel isolated. you are emotionally tired, exhausted. All right. Now, praising her for doing what the right thing for her father, this is not good. All right. Why? The more you put demand on the caregiver who is having a burnout, okay, that you would make her feel guilty if she would, express her, emotions that I'm so tired already. You're not addressing her problem that she is what? Getting depressed and misses her personal social life. You do not praise these caregivers. Why? Because you're more putting demands on them that you have to take care of your parents. Instead, you did not address their problem. Okay? Number two is wrong. What else? Um, okay. Explaining to her that her feeling of loneliness are normal and will pass. Okay, does it pass right away? You are feeling
No.
depressed already. Okay, no. All right. So very important for us nurses that support groups help, right? Support groups. So you have to suggest to, maybe you can recommend like support groups that you can attend to. This support groups, okay, this will definitely help you, because again, in the support groups, you share the same problems that perhaps this person have, or this other person, how did they able to manage this one. All right, what else? Educating, very important that you have to remind her or educate her that these are, the signs and symptoms of being depressed, because this will definitely give you an insight. All right, what else? Exploring ways her to interact with friends and family more. So other ways perhaps you can communicate through social media and this and that, and identifying what aspect of caring for her father causes her to be isolated. It's very important, so that by identifying these aspects, you would know how to manage. Okay, you would give recommendations, or perhaps let's do this way, this and that. Okay, so answers to these are 1, 3, 4, and 6. Okay. Another question. The nurse knows that the priority nursing care for a client with dementia is, okay, is it preventing further deterioration? All right. Number 2, finding suitable nursing home placement. Number 3, supporting family caregivers. Or number 4, preventing injury.
Preventing injury.
Very good. Okay. Preventing injury. Very good. All right. So, any questions, nurses?
No.
No. Okay. So let's move on to our, okay. Okay, let's move on to our eating disorders. Okay, eating disorders. Who loves to eat? Okay, everybody loves to eat. Okay, it's just that there is some problem, or there's some like most especially the adolescents, because of the peer pressure, they avoid eating. Okay, they do not want to eat. It's because they have this concern that every time when I eat, I would gain weight, and then when I gain weight, I do not feel like I'm the perfect already for my friends. First eating disorder that we're going to talk about is your anorexia nervosa. All right. So, anorexia nervosa, this is an intense fear of gaining weight. A person has a fear, of food, or even like gaining weight, to the point that, okay, this can actually cause problem, right? So as you can see, this is an actual picture, okay, of a model, okay, who suffered from anorexia nervosa. Who else? The lead singer of the band Carpenter, if you're familiar with that band, Carpenter, right? She died from anorexia. All right. The problem here is that you are depriving yourself with the needed nutrients, calories in order for us to survive all throughout our day-to-day activities, or our actions. So in this, the problem in your anorexia nervosa, they you have to specifically address this. Okay, address in a sense that you are targeting two treatments for these clients. Okay, psychologically and what physically. Okay, psychologically, it's you have to identify, let them have that thought pattern that what you're doing to yourself, you're slowly killing yourself by not eating, which is not normal, right? Because these, most especially the teenagers, they're the ones who are preoccupied with the thought of being perfect. And sometimes, a personality of a women, because this is more common in women than men, okay, who are anorexic. They are perfectionists, all right? Perfectionists in a sense that if my waistline is 23, I stand among, or I stand out among my friends. Okay, I will be the center of the attention. Okay, I am perfect. They have that type of personality. Okay, being perfectionist, OCPD. All right. Now, obsessive compulsive personality disorder. Obsession, their obsession is what? Okay, they're thinking that I have to be this and that. And their compulsion is through what? Avoiding food. They do not eat. Even drinking water, no, they do not, because they think that, okay, when they drink water, they will gain weight. Okay. Now, developmental pressure, being adolescent, and social cultural pressure are one of the common cause as to why, okay, a female would have anorexia nervosa. And even, okay, a conflict in the family. Okay, a conflict in a family in the sense that, okay, if your parents are so preoccupied with their conflicts, okay, it is somehow establishing or getting attention from their parents that, okay, they're no longer attending to my needs, then probably I should do this and do that, and it's like placing a demand from their parents, all right, of being, having a control of themselves, okay, for clients with anorexia nervosa. Again, the problem with this is that this can actually lead to death if not managed, all right? Lead to that if not managed. Now, manifestations of these clients, okay, they do not have the appetite, okay, they have um, refusal to eat, compulsive exercising, even in the middle of the night, even though that they are in their room, they're lying down in the bed, they are doing exercising. All right, what else? Amenorrhea for 3 consecutive cycles. All right, they do not menstruate because, again, due to hormonal problems already. Vital signs problems, all right, or abnormalities. They have decreased temperature, decreased pulse, and decreased blood pressure. All right, what else? Esophageal varices. Okay, why esophageal varices? Because they want to induce, or they would induce vomiting. All right, they would try to like stimulate the vagus, all right, and for them to vomit. All right, what else? Dry, scaly skin. It's because they're not getting enough nutrients already. All right, presence of lanugo on extremity. Okay, presence of a lanugo in the extremities. Now, the presence of lanugo or hair, this is actually more of a compensatory mechanism of our body to provide a warm feeling. Okay, you do not have muscles anymore. You do not have fats anymore that would somehow insulate the body. So, as a normal mechanism, or in response to that, no muscles, no fats, okay, your hair would grow. All right. Now, what else? There is also cyanosis or numbness on the extremity. Okay. Severe muscle wasting or kakiksha. All right. Severe muscle wasting or kakiksha, and extensive caries. Okay. Extensive caries on your teeth. Why? It's because what you are vomiting already are hydrochloric acid. All right, what you're vomiting are hydrochloric acid that would somehow damage the enamel of your teeth. All right, so this is an actress, a model. Her name is Rachel. Okay, Rachel Farouk. All right, so and this is the husband of Rachel assisting her. Okay, again, the problem with this is that this can actually cause you know, death. Okay, so very important when you care for these clients with anorexia nervosa, you have to be non-judgmental. All right, do not impose on them that, oh, you know what, you're so harsh on yourself, you've look at you now, you're a burden to your family. No. Okay, because what they perceive or with their personality of being perfection, okay, is real to them, that they feel like they have a control of every situation by being perfect. All right, so as a nurse, again, it's a no-no that we are being judgmental. All right, now you have to re-establish eating behavior for these clients. Eat at least 30 minutes, and very important that you have to sit down or be with the client after meal. All right, this is more of like looking out for the client, because usually after meal, if they may eat, then they would tend to go, like say they would go in the bathroom. Okay, they would induce vomiting to relieve what they have eaten. All right, because again, they have that fear of gaining weight. Now, another management is that you have to weight them daily at the same time using the same scale. All right, and clothing, and make sure the type of clothing would be what? Light clothing for these clients. All right, light clothing. So weight daily, same time, let's say at 8 in the morning. Okay, same scale and clothing. Wait the client after the client voids. Okay, after defecating or after the client voids. So assist the client in expression of feelings, because oftentimes, you know, there is actually a conflict with their emotions, that, oh, the reason why as to I'm this, I'm that, I'm really having to have a control of myself because I wanted to be in the society where I think that my friends would accept me if, you know, my body image is this and that. All right, and speaking of body image, nursing diagnosis for these clients is what? Okay, that would be your nursing diagnosis for these clients would be disturbance in body image. All right, disturbance in body image. Anorexia nervosa, disturbance in body image. Now, our therapeutic goal for these clients is that since their problem is their weight, all right, our therapeutic goal should be what? For them to gain back to their normal weight. All right, so addressing that, aside from reestablishing their eating behavior, would be helping them give or have an insight that with their idea of being, you know, not eating because if they would eat they would gain weight, and because they would gain weight they do not feel like you know, they're not accepted, they're no longer perfect. So aside from that therapeutic goal of reestablishing behavior, reducing their ideation. Okay, reducing ideation is also one of our therapeutic goal. All right, reducing their ideation of being perfect, reducing the ideation of whenever they eat that, oh, this would cause me to gain weight, or simply addressing their conflict, what they have in their mind. All right, so reducing ideation is another therapeutic goal for these clients. Now, because of that severe weight loss, these are the criterias for a client that is having anorexia nervosa. all right, that you need to let them be in the hospital. Okay, put them, or okay, let them be not just in the mental facility, but this time, okay, in the hospital, because most often these clients with anorexia nervosa, it all starts in the home. All right, what when they go to the facility, or in let's say in a group or a facility that cares for a client all exclusive with eating disorder, that's when they recognize, or the parents recognize, that their child has a problem. Or most often, aside from that, okay, would be the warrant for hospitalization. All right. So warrant for hospitalization, or criterias for hospitalization for these clients, would be if there is already a failure to gain weight in outpatient setting. Outpatient setting would be at their home. All right. They fail to gain weight, or there is drastic loss of weight. What else? Loss of 30% of the body weight for 6 months. 30% of their body weight within the span of 6 months. All of a sudden, 3 months, you saw your friend, and then 3 months after, wow, it's like your friend is emaciated or kakiksik. So extreme muscle wasting, skin and bones. All right. Now, vital signs, okay, where their blood pressure is less than 70, systolic pressure less than 70. Okay, that only means that your heart is no longer, okay, functioning very well. All right, pulse rate less than 40 beats per minute, and the temperature less than 36 per minute. Okay, so these are your criterias for a client with anorexia nervosa that warrants them to be hospitalized or to seek medical attention right away. All right, so on the other hand, another eating disorder, okay, we have your bulimia nervosa. Now, in your client with anorexia nervosa, if they have the fear of gaining weight, and they do not eat, a client with bulimia nervosa, they are the ones that would keep on eating. Okay, they love to indulge. They are the ones who binge food. And usually, binging is due to a stress. Okay, it can be a stress related to work. Your boss is so demanding. Okay, and here you are, because of the stress, you would now tend to express, or you release your stress through food. All right. Now, imagine you are at work, your boss placed so much demand on you. You're completing a project, and here you are, because you're so stressed, you would uh, tend to release it, and on your way home, driving, it's just a 15 minutes drive from your office to your place. You drop by at a convenience store, you drop by at 7-Eleven, you bought a bag or a chips of Lays, all right? And you saw a drive-through. You went through a drive-through to a McDonald's. Okay, you ordered a Big Mac, and on your way home, driving on your way home, you were already able to consume that Big Mac. You were able to consume that bag of chips. And when you notice that, oh, it's already gone. Oh my God, I have eaten all those. And that's the time that guilt feeling would set in. Okay. Oh, I cannot. Oh my God, I feel like so, I think it's not appropriate for me to consume this and that. I feel like I'm so, you know, I feel like I'm so like, oh, this person that is a monster of eating food, able to consume, it's not appropriate for my image. And that's the time when the guilt sets in, they would do what? Okay, they would induce vomiting. All right. They love to binge food, and at the same time, because of that guilt feeling, okay, that they address themselves as, let's say, oh, I should not act like this, I have a body image, or I have an image that I have to protect. I don't want them to know that I'm able to consume all this. I binge when I eat. So that's the time, not to be evident in their weight, that's the time that they do what? Okay, binge, or indulging, or inducing vomiting. Okay, that is your bulimia nervosa. indulges in binge eating followed by purging behavior. All right, followed by purging behavior. Etiological factors or theories, we have biological predisposition, psychological predisposition, and family dysfunction. Family dysfunction, again, still the same. If you have a conflict between your husband or let's say your parents, all right? So manifestations for these, they are preoccupied with their body shape and their weight. All right, what else? Binge purge, attempts to lose weight through diets, okay, enemas, cathartics, worst, your amphetamines or your drugs, okay, and even diuretics. All right, but take note, nurses, diets, enema, cathartics, amphetamines, diuretics are also seen in your clients with anorexia nervosa. All right, they would do enema or anything that would help them lose weight. All right, attempt to lose weight, diet, enemas, cathartic, amphetamines, and diuretic is not only obvious or evident to your client with bulimia nervosa, but also to your clients with anorexia nervosa. Right? They also have mood swings, electrolyte imbalance, okay, still the same in your clients with anorexia nervosa, and induces vomiting. All right, induces vomiting. So again, management for these clients, be non-judgmental. All right, be non-judgmental, set limit to binge eating, assist these clients in expression of feelings, monitor their elimination pattern. All right, work on exploring self-concept and establishing identity. All right, work on exploring self-concept and establishing identity. Help them think that whenever you feel stressed, when you binge, it's normal. Okay, everyone does binge, most especially when we are at stress. Hence, we have this like stress eating, right? We have these episodes of stress eating. And yet again, in a client with bulimia nervosa, for those who did not establish their identity or their concept that, this is normal or you should not be so hard on yourself. Okay, so let them or assist them in exploring. Okay, any questions? Any questions? None so far? Okay, let's try to answer this one. A client with anorexia nervosa is a member of a pre-discharge support group. The client verbalizes that she would like to buy some new clothes, but her finances are limited. Group members have brought some used clothes to the client to replace the client's old clothes. The client believes that the new clothes are much too tight and has reduced her calorie intake to 800 calories daily. How should the nurse evaluate this behavior? Right? Is it normal behavior? Number two, evidence of the client's disturbed body image. Number three, regression as the client is moving toward the community. Number four, indicative of the client's ambivalence about hospital discharge. Okay, good job. All right, this is simply an evidence of client's disturbed body image. Okay, take note, the client believes that the new clothes that were lent to her are too tight, okay, and that causes her to restrict her calories intake to 800 calories daily. Is the problem or is the adhesion here reduced in this scenario? Yes or no? Is the adhesion here addressed or reduced? Yes or no? Anyone? Is the idea here, okay, idea of, correcting my thoughts that I should not be strict or I should not be hard on myself, is it reduced or not? No, right? No, very good, CG. Okay, no. Why? If in if your idea of being perfect, or if your idea not to restrict calories anymore, when somebody lend you a new clothes, then you would not think that, okay, that new clothes are too tight. All right, and hence you will not restrict your calories. Okay, are we clear? Okay, another question. The mother of the female adolescent The mother of the female adolescent tells the nurse that she found several boxes of Dulcolox in her daughter's room. Okay, what is your Dulcolox?
Liquid.
Laxative, very good. The nurse assesses the adolescent and notes a normal body size of her weight. Is somebody moving? For some reason, you know what? It keeps moving back and forth, and it's kind of like irritating. I'm not I'm not like holding my mouse at all. So if any one of you who has a control of this slide, please stop making any movements, okay? So again, the nurse assesses the adolescent and notes a normal body size for her height. Which question should the nurse ask the mother? All right, which question? Is it number one, how long does your daughter had problems with her bowels? Number two, how often does your daughter participate in school activities? Number three, does your daughter spend long time in the bathroom after a meal? Or number four, has your daughter been feeling depressed about how she looks? Okay, so again, the use of laxatives, okay, inducing vomiting, okay, these can be a sign, okay, of a child with bulimia. Take note, the nurse assesses the adolescent and notes a normal body size for her height. So this can be a problem considering your bulimia nervosa. All right, so it's very important that you have to, okay, the nurse should assess, okay, possibilities of what? Your, okay, bulimia nervosa. Because again, these clients would what? Use of enemas, all right? What else? They would induce vomiting, and oftentimes they would go to the washroom after meal. Okay, number four is the answer. Okay, so on to our substance and related and addictive disorders. Okay,
Ma,
substance
sorry, you said number 4 is the answer or number 3?
number three. Okay, did I mention four? Did I say four?
Why not 4, ma'am?
Okay, has your daughter been feeling depressed about how she looks? Take note, this is the nurse assesses the adolescent about normal body size for her height. But you notice several boxes of Dulcolax. Okay, so normal size, and yet the client is what? Abusing Dulcolax. Okay, this is already an indication that the client is what? Having bulimia nervosa. So you have to address right away. Ask directly. Does your daughter spend long time in the bathroom after meal? Okay, that is also the reason why, you have to sit with the client after meal. Remember, not just in your clients with anorexia nervosa, okay, but overall those with what? Okay, those with eating disorder. Okay, ask them directly. Has your daughter been spending too much hours in the bathroom? Because this is where they do what? Induce vomiting. They would drink Dulcolax and then eliminate, or just remove everything what they have eaten. Okay, are we clear?
Yes.
Okay, so again, clients with bulimia nervosa, they're not thin, they have a normal weight. It's just that because of the stress, they binge eat, but however, they purge. Okay, so they eat a lot, but because of that guilt feeling, they purge. And oftentimes, the only difference between your bulimia nervosa and your anorexia nervosa is that bulimic clients are within the normal weight. Okay, are we clear?
Yes.
Are we clear? Okay, clear, nurses? All right.
Yes,
Yes.
please.
So, okay. So, on to our substance related and addictive disorders. Okay. Substance related and addictive disorders. So, I have a key terms here that would help you. Okay. Be familiar. All right. When it comes to substance dependence. So, substance dependence, this is already a pattern of repeated use of substances. Okay. It can be alcohol, it can be stimulants, okay, which would usually result in tolerance, okay, withdrawal symptoms, and compulsive drug taking behavior. You are already dependent to the drugs, all right, or that substance. Substance tolerance is the need for increasing the amount of the substance to achieve the desired effect. So when you started, let's say when you started with the amphetamine, you were just sniffing it, and then later on, as your body develops tolerance, okay, from a simple sniffing of that amphetamine, or let's say drinking one drug of your ecstasy, you do not anymore receive the effect. Okay, so that's why you now increase. All right, you increase the amount of the ecstasy from one tablet to two tablets to three tablets to four tablets or even five tablets. Okay, substance abuse. All right, this is a recurrent and significant use of substance regardless of the harmful consequences. You're now addict. Okay, you are now considered, all right, you are now, you belong to what is we call this your addictive behaviors or disorders. All right, substance withdrawal. Now, this occurs when an individual experiences a decrease, okay, in the blood level of substance in which the individual is already dependent. Now, when there is already a weaning of, let's say, for example, an alcohol. Now, with that, okay, weaning or decrease of alcohol in your blood, that is a time that you experience like untoward effects or withdrawal effects. And oftentimes, those effects are undesirable. That is why, all right, a person, okay, to avoid that untoward effects or withdrawal effects, they would now drink again, okay, or they would now use the drug again. All right, that is your substance or addictive behavior. It all started with dependence to drugs. Okay, later on you develop that tolerance, increasing the dosage, and worse, you are now abused. Okay, you are now abusive to either your alcohol, okay, or even those um, narcotic drugs, okay, narcotic or even opioid drugs, all right, and withdrawal. And because of these withdrawal, then you do not want those effects. That's why you would revert to drinking and taking drugs. All right. So, what are the factors? Okay, what are the key factors as to why a person would have a substance abuse or addictive disorders? This is actually due to perhaps peer pressure when you are adolescent. You find happiness when you always go out with friends, you drink out with your friends, all right, and it can also be a sort of rebellion in the sense that, again, another conflict in the family. All right, conflict in the family, you are seeking attention from your parents. All right, coping mechanism, it can also be a coping mechanism. Let's say you want to avoid that sad emotion, you tend to drink and drink and drink just to forget any past event that happened in your life that you did not want to or experience, to relieve that emotion again, coping mechanism. Depression could also be one of the factor as to why the client would have a drinking habit or a substance abuse. Okay, what else? Grief or loss of an individual, low self-esteem. All right, low self-esteem, because when you drink, depending on there is a certain level of the alcohol in our blood wherein this would give us a euphoric effect or euphoria. Now, if you are a shy type, all right, let's say for example you are a shy type. Now, to somehow increase your confidence, all right, you have that euphoric feeling, okay, before going in the stage, you would drink, right? You would have to like a one shot or two shots. Same thing with your colleagues, let's say with your colleagues. You went out, you celebrate, okay, and then you rented a video game machine. So here you are, a very shy type of a person, and when your friend offered you, oh, go ahead and sing, all right, and then you said, oh, no, no, later, and then your friend offered you drinks. You had drinks already, you had two shots of beer already, and here you are, you know because of that feeling of inhibition, euphoric. That's the time that you grab the microphone and you do not want it to give to your friends. Okay, reality, that happens, right? Another, we have your codependency, refers to the presence of coexisting behavior present in significant others. All right. Hence, alcoholism, one of the factors as to why, okay, alcoholism um, is one of the problems that we face today. It's because, okay, it's in the genes actually. If your parents are alcoholic, all right, 80%, 90% of which you'd also become alcoholic. It's in the genes. All right, codependency. Now, please take note of the effects of these stimulants and your depressants. All right, intoxication, when our body has these stimulants, so effect of which is high. All right, when there's already a weaning off or no stimulants in our body, so withdrawal effects of these are down. Okay, now if you're taking depressants, when you are intoxicated of depressants, okay, effect of which is actually down, all right, and withdrawal effects would be high. All right, we'll try to identify later on, most especially with your alcohol, because alcohol is a central nervous system depressant. When you are intoxicated with your alcohol, hence the effects, okay, are more of your depressants. And withdrawal effects, okay, now this is a time that you will have agitation, tremors, all right, irritability, okay? So that is the withdrawal effect. Intoxicated stimulants, example would be your amphetamine drugs, okay? You're high, right? When there's no longer amphetamine in your blood, all right, withdrawal effect is that if you cannot, when you are intoxicated with amphetamine, again, it seems that you are awake 24 hours, 48 hours, all right? But if it's no longer, okay, there's already weaning of that amphetamine drugs, 48 hours, this is the time that you are, always sleeping already. All right, you do not have energy. You're becoming lethargic, and because of that lethargic feeling, decreasing energy, you do not want that effect. That's why your body is now, okay, looking for that effect of the drugs, which is amphetamine, what makes you feel high. All right, same thing with the depressant. Okay, it makes you feel calm. It somehow makes you feel, forgetful about, let's say, past event that happened, because when you drink, when you are let's say have too much drink already, you tend to pass out and then go to sleep. All right, so that is your effects of the depressant and the stimulants when we are intoxicated, and withdrawal effects. So first, let's talk about your alcohol abuse. Okay, alcohol abuse, again, this affects the society, this affects the family. All right. Alcohol is a central nervous system depressant. The problem with here is that it develops physical dependency. Okay, the biological need for alcohol to avoid physical symptoms. Okay, now I had a friend before that he's a very heavy drinker, and because his body is already adapt to alcohol, next thing in the morning, if there's no already like there's already withdrawal effects of the alcohol, he have this tremors and he doesn't like it. So that's why he would now tend to drink again just to address the tremors. All right. Psychological dependence. All right. They crave for the effects of the alcohol. All right. Feeling of inhibition, feeling of euphoria. That's what they crave. All right. And sometimes it's fun to have drinks with our friends, right? Especially if you celebrated, you pass the NCLEX, you invite your friends, you're so happy, there's a celebration. It's fun as long as it's in minimum, right? It's not every day. Because if it's already every day, then you are now considered, okay, alcohol dependent. Okay. Now, theories of causation, again, genetics. If your parents are alcoholic, then you are alcoholic as well. Environmental factors, okay, your friends, your colleagues, after out of work, Friday, oh, you're supposed to be drinking because it's the end of the week, it's the end of the work week. You're supposed to be out, you're drinking with your friends, but here you are studying and listening to the discussion. Probably after this at 11 tonight or 12, you'll go partying, okay, and drinking. Because again, you want to go out with your friends. Interpersonal factors, okay, interpersonal factors. You have this a problem within you that you wanted to somehow, forget about it, right? That's why after this review, you would go out with your friends and drink. I don't know if it's open already in Australia. All right, interpersonal factors. Okay, so the problem with, again, your alcohol abuse is that it can develop complications, right? So here are the several complications that we have to take down. So what are those? Peripheral neuropathies, okay, because due to, or this is basically due to vitamin B deficiency. Now, in your alcohol, you keep on urinating, right? You have this because you're drinking, it's liquid. Your bladder is always full. You keep on urinating. Along with what you urinate are electrolytes or vitamin B. Okay, then develops your peripheral neuropathies. Korsakoff syndrome due to thiamine deficiency. Still, you are lacking vitamin B. All right, Wernicke's encephalopathy. Okay, this is actually an acute neurological condition characterized by episodes of confusion, okay, or ataxia, uncoordinated body movement. All right, hepatitis. Okay, hepatitis. Hepatitis, okay, inflammation of the liver. Remember, your liver is the one that detoxifies the blood. And it so happened that your blood has a high level of alcohol. All right, so, and worst, okay, liver cirrhosis. All right, the end stage, okay, liver problem, liver cirrhosis. Esophagitis or esophagitis, inflammation of the esophagus, and even pancreatitis, all right, inflammation of the pancreas, all right, inflammation of the pancreas. You're putting too much workload of your pancreas to somehow detoxify, okay, or for your body to absorb these carbohydrates. Your pancreas would release your amylase, those pancreatic juices. All right, so you have too much alcohol, it adds workload in your pancreas. All right, same thing with your liver. It adds too much workload in your liver because every time when your liver, okay, your blood is full of alcohol, it keeps on detoxifying. Okay, so worst complication would be your liver cirrhosis, because again, once you're diagnosed with your liver cirrhosis, is there a cure? Is there a cure for liver cirrhosis?
No.
No, right? So, and oftentimes, as to why the person becomes alcoholic, okay, it's because, again, defense mechanism, all right, of these alcoholic clients are number one, denial. Okay, they deny that they are alcoholic. And sometimes, to defend, they would do rationalization. They would keep on saying, oh, it doesn't, that. All right, rationalization. Okay, and projection. Okay, you project your idea. Oh, you know what? My father is alcoholic. So it's pretty normal because my father was drinking. So you also project that, okay, action of your father into you. All right, projection, defense mechanism. Now, cage screening questionnaire is very important to identify that the client is already alcoholic. However, it's not that much effective. Why? Because again, these clients, okay, would deny that they are alcoholic. So cage questioning, okay, we have the letter C. Have you ever felt the need to cut down on your drinking use? Okay, letter A, have you ever been annoyed at criticism of your drinking use? Letter G, have you ever felt guilty about something that you have done when you have been drinking? Letter E, have you ever had an eye opener drinking first thing in the morning to get going or to avoid withdrawal symptoms? And cage screening questionnaire is often asked for the clients who are already, okay, or they would voluntarily admit themselves, okay, into a rehab, or it could be involuntary admission, okay, into a rehab. But again, they would oftentimes, okay, say no to these. All right, they would know or say no to this. So what are the effects of alcohol in our body? What are the effects? So 0.2, 0.6, slight mood changes. All right, it lowers down the inhibition and impaired judgment. So 0.6, this is the time that you're no longer shy. You grab the microphone, okay, in the video, okay, and then you sing all throughout the party. All right, 0.8, okay, 0.08, you're now considered drunk, all right, legally drunk. 0.15, there is already impaired balance, okay, or ataxia, movement coordination. So this is the time that when you walk, okay, you can no longer have that straight walk, all right, difficulty standing, walking, and talking. All right, so I'm pretty sure most of you students can relate to this, right? Difficulty standing, walking, and talking. So do you guys agree with me? Did we all experience this one? Come on, we're all adults. Okay, any one of you who does not drink, okay, you should start drinking now. It's fun, actually. It's fun to be out with your friends, with your classmates, and drink. But again, let's keep it in minimum. All right. 0.20, decreased pain and sensation. This is the time that you notice upon waking up, oh, I did not know I had this. All right. Oh, where did I get this? Okay. And there's a cut. You did not feel pain at all. Okay. Because again, alcohol level 0.20. 0.30, this is the time that you diminish your reflexes and you're somehow semi-conscious. Okay, this is the time that you are in the group and here you are, you notice or notice your friend who's already doing this. Okay, semi-conscious. And then when you call your friend, hey, and then your friend would like, yes, and then go back to this, being semi-conscious. All right, 0.40, loss of consciousness already. This is the time that they pass out. No matter how you wake them up, they cannot be awakened. Okay, and 0.50, okay, death. Most especially if your body cannot tolerate the alcohol. All right, death can occur. And sure enough, let me just share this to you. Um, just this year, it was New Year's Eve. Okay, there had been a group of flight attendants who rented a hotel room. There had been a party. They have been drinking, and sadly, that party turned out to be a tragic event. Why? Because somebody died out from that party. Okay, they were suspicious, or investigation, think that probably the person or the girl was raped, but evidence show, or in the investigation showed that she was not raped. Okay, it's just that her body, she was intoxicated with alcohol. Okay, her body was not able to take the amount or the level of alcohol. All right, 0.50. And sometimes, just to add this, they would have that in decreased pain and sensation. They would also have blackout or memory loss. Okay, they had a they have these episodes of memory loss. They cannot remember what happened last night in the party. All right, so again, that is your alcohol. And what leads them to become alcoholic? It's because they do not want the alcohol withdrawal. And usually alcohol withdrawal, this peaks 24 hours to 48 hours. So signs and symptoms, we have increase, right? Alcohol withdrawal, because again, your alcohol is dependent. Intoxicated, down. Withdrawal effect, high or increase. So take note, we have your anxiety, nausea and vomiting, easily startled, hyper alertness, hypertension, they cannot sleep, they are irritable, there's jerky movement, possible has hallucination, illusion, delusion, or vivid nightmares, or your delirium tremens, reports of feeling of shaking inside, the tremors. Okay, and seizure that usually appears for 7 to 48 hours after cessation of alcohol, tachycardia, and tremors. All right, alcohol withdrawal, if you know the effects, intoxicated, down. Withdrawal effect, high. So look for the options in your exam that causes, okay, increase or high effect. All right, are we clear? If you'll be asked in your exam, ask SATA. Okay, so delirium, okay, withdrawal delirium or your delirium tremens, this usually peaks 48 to 72 hours and usually lasts 2 to 3 days. Okay, lasts 2 to 3 days. So what are these effects? Okay, we have agitation for 3 days. You have that agitation. Okay, anorexia, anxiety, deliriums, diaphoresis, disorientation, fever, hallucination, and delusion. You cannot sleep for 3 days. You're having tachycardia and hypertension. And take note, nurses, this is a medical emergency. Medical emergency in a sense that, okay, because of your hypertensive or high blood pressure. Okay, do we have to address alcohol abuse? Definitely, because this affects the socioeconomic status of the family. Okay, instead that the father provides for the family 100%. Okay, what happens now, it's because you have drinking problem, you crave more of alcohol, then you would deprive your family of the support financially. So management for your alcohol abuse includes disulfiram therapy. Okay, disulfiram therapy, this is basically a type of your behavioral therapy, okay, or your aversion therapy, wherein you are somehow punished every time you have alcohol in your body, or even like smelling alcohol. All right, so take note, in your disulfiram therapy, you have to establish a no alcohol policy. All right, 12 hours prior to the initial dose of your disulfiram, all right, and 14 days after the therapy. No alcohol 12 hours prior, all right, and 14 days after the therapy, all right. Um, it's very important that when the client is admitted for the rehabilitation, take note no alcohol policy 12 hours prior. So as an assessment, you have to ask the client, when was your last drink? All right, when was your last drink? Because if you would give the client disulfiram, all right, 2 grams of disulfiram, if you will give this, and let's say the last drink of the client is 4 hours, now these clients would have a severe adverse effect. And usually, if you give disulfiram within 4 hours after their last drink, it begins 30 minutes after drinking that they would have, okay, facial flushing, sweating, throbbing headache, neck pain, nausea, vomiting, hypotension, tachycardia, respiratory distress. All right. And what they do not like about this much is the severe headache. And usually, this severe headache would last up to 2 hours maximum. All right. That's why it's very important. You have to ask the client, okay, prior to taking the disulfiram therapy, ask the client, when was your last drink? All right, are we clear? And while they are in disulfiram therapy, take note no alcohol policy. So instruct the client to avoid substances that contains alcohol. Okay, instruct the clients that avoid substances that contains alcohol. Can you give me an example of those substances that contains alcohol? Can you give me an example?
Cough syrup,
Perfumes.
cough syrup,
Cough syrup.
Perfumes.
Very good. Okay, cough syrups. All right, what else? We have
Perfumes.
rubbing compounds, okay, vinegar, mouthwash, aftershave lotions, and even perfumes. Okay, so you do not want to give them, or they should not be taking over-the-counter drugs. Your cough medicines, these are over-the-counter drugs, OTCs drugs, rubbing compounds, okay, even vinegar, mouthwashes, and aftershave lotion. Okay, even though that they would just apply aftershave lotion on their face while they are in disulfiram therapy, okay, they would now 30 minutes after, they would have this throbbing headache, facial flushing, sweating, diaphoresis, and again this would last, okay, at least or 30 minutes to 2 hours. All right, so very important that you have to ask the client, when was your last drink? All right, when was your last drink? Another management would be your, okay, group therapy. All right, group therapy, we have your Alcoholic Anonymous for the client, Al-Anon for the wife, and Al-Ateen for the children. All right, Alcoholic Anonymous, Al-Anon, and Al-Ateen. All right, are we clear? Clear, nurses? So I have here a list of commonly abused substances. So I will, no worries, I will give this to you. All right, I will give this to you. You will have a copy of this one. Okay, so we have your amphetamine, stimulants. Amphetamine is a stimulant. So intoxication effects, we have your hyperactivity, you cannot sleep, all right? You have dry mouth, euphoria, increased vital signs, weight loss, okay, and loss of appetite. All right, withdrawal effects, okay, fatigue, depression, agitation, apathy, lethargy, and craving for more. All right, we also have your opioids. So opioids, these are your heroin, meperidine, morphine, codeine sulfate, methadone, oxycodone. So when you are intoxicated of this, okay, it could cause you to have constricted pupil, decreased respiration, drowsiness, hypotension, slurred speech. Okay, opioids, these are downers. Okay, opioids are downers. Okay, withdrawal effects would be irritability, rhinorrhea, okay, diaphoresis, cramps, nausea, and vomiting. We have another, okay, commonly abused substances, your hallucinogens. Okay, so hallucinogens includes your lysergic acid diethylamide or your LSD. We have your mescaline, okay, your cyclobin, or your mushrooms. Are you familiar with this one? Mushrooms? Are you familiar? Okay. Um, anyone? Navdeep, are you familiar with your mushrooms?
Yes, ma'am.
Yes, and even this, I forgot. Oh, Mike Tyson, the famous boxer, he admittedly said that he's taking cyclobin. All right, so intoxication effect, we have blank stare, dilated pupils, diaphoresis, increased vital signs, violent behavior, paranoia, seizure, and tremors. Withdrawal effect, we have your flashback and agitation. Okay, we have here your cannabis sativa or your marijuana. So back then, this is considered an abusive substance, but because of the good effect of your marijuana, so it's now considered as a medical treatment. Okay, a medical or a herbal or alternative treatment. Okay, so we have, I think, in Arizona, states in Arizona, most of the states in the US. I'm not even sure in Australia if it's already considered a medical, a medical treatment, or that is you can purchase if you have a car that you are allowed to take medical marijuana. So effects, intoxication effects would be euphoria, talkativeness, anxiety, bloodshot eyes. Okay, withdrawal effect, okay, lack of appetite, depressed mood, and headache. Okay, so these are commonly abused substances. So let's answer this practice question before we proceed with another topic. Okay, so the nurse is monitoring a hospitalized client who abuses alcohol. Which findings should alert the nurse for the potential for alcohol withdrawal delirium? Okay, is it hypotension?
No,
Wrong
ma'am.
right away, right? Okay, withdrawal. Alcohol is depressant, so withdrawal effect is high. So no alcohol withdrawal. Okay, there you go. The answer is number 4. Okay, good job. So we have hypertension, okay, change in the level of consciousness, and hallucination. All right, good job. Okay, so, okay. It's already 5:53 in my time. Would you like to have a break or would you like to continue?
Break.
Break, ma'am.
Break, ma'am.
So be back 10 minutes after. Okay, so
Yes.
be back at what time is it in your end? 8 or
8:53.
8:53. Be back at 9:03. All right.
Okay.
Hello, everyone. Are we back? Hello. Are you here with me?
Yes, yes, ma'am.
10 minutes went by so fast, right? So, okay. Anyhow, we're about to end our lecture, and I hope that I can really cover the psychopharmacology part or the medication, okay, because this would really help you a lot. So, domestic violence, okay, so let's talk about domestic violence. So, this domestic violence not only affects or the victims would be the wife, but also the children and the elderlies. All right. So, first, let's talk about your child abuse. Okay. So, this is quite sensitive topic, you know. So, if any one of you may have experience of being abused when you were a child, so you know, you can just message me or approach me, or I hope that you are able to recover now. All right. So, child abuse can be a form of your neglect, physical, sexual, and okay, happened to my okay, and emotional. All right. So, neglect can be seen in the form that you notice that a school age child has inadequate weight gain. Inadequate weight gain, it's because, you know, they tend to eat junk foods. They tend to eat unhealthy food in order for them to survive. All right. They have poor hygiene, consistent hunger, inconsistent school attendance, and constant fatigue. All right. These are a sign of neglect because the caregivers or the parents, okay, do not attend to the needs of the child, most especially with their foods and their hygiene. All right. Physical abuse, you would note bruises, burns, and even fracture. All right. Bald spots on the scalp here. Apprehensive child, or when we say apprehensive child, you are always fearful. All right. You're easily startled when you see some stranger similar to your abuser. You are scared. All right. They lack of crying when approached by stranger. They already developed that tolerance in them. All right. What else? Emotional, speech disorder, learning disorder, and suicide attempt. All right. Learning disorder, it's because our first teacher is our parents, right? Our parents are the ones who teaches us like simple mathematics or even reading or even like, you know, with the alphabets. Like, but since your parents are, you know, the abuser, they tend to neglect that as well. Worst is that, you know, if it's sexual, all right, sexual, you would note this that the child may have difficulty walking or sitting, okay, torn or stained bloody underclothing, pain, swelling, or itching in the genitals, bruises or laceration in genitals or anal area, and this child is unwilling to change their clothing or even to expose their body because every time, you know, the trauma that they developed in them, that every time when somebody would remove their clothing, that sexual harassment or sexual attempt may occur. All right. Or hence, in the child abuse, we have this rape cases. All right. Rape cases. And not only for your school age child, this abuse can also occur in your infants. Okay. And this, if it's more of your infant, this is what we call your shaken baby syndrome. Shaken baby syndrome, this is caused by violent shaking of an infant. Okay, if most especially if the infant is always, you know, crying, so the caregiver or the mother here or the parents would just like, can you not stop, can you stop crying, you know, and this and that. They're kind of like frustrated, they're kind of like annoyed or irritated by the cry of the infant. But because of that violent shaking, this can actually result in intracranial trauma that can lead to edema and death. Remember, the fontanelles of the infants are not yet closed. Okay, so because of that shaken baby syndrome, okay, this can actually this can lead to intracranial trauma. Now, assessment findings would include full bulging fontanelles. Okay, full bulging fontanelles. All right. Now, again, shaken baby syndrome, child abuse, priority management here is safety. Okay, safety of the child and the infant. So remove the child from immediate danger. And where do we report them? To the Child Protective Services. All right, Child Protective Services. Child abuse and your shaken baby syndrome. Now, abuse also occur in your elderly. Okay, so it can be a form of physical abuse, emotional abuse, neglect, and economic exploitation. Physical abuse can be a form of your pressure source. All right, so skin tear, abrasion, and even bruises. Okay, very common would be the pressure source. The caregiver, the parents, okay, fail to turn the elderly at least every 2 hours. Okay, physical abuse. Emotional abuse, you would see these elderlies are withdrawn. All right, they lost social interest and self and social activities. All right, neglect, okay, they are unkempt, disheveled. All right, malnourished, lacking physical needs such as what, hearing aid and um, glasses and even dentures, okay, for them to properly chew the food. All right, hearing aids for these elderly to be able to hear when communicating, and even glasses. All right, so if they do not have this, take note, these elderlies have pensions, right? They can provide, they can purchase for like hearing aid, dentures, or glasses. Now, if they do not have this, then that could already be a sign of economic exploitation. Now, economic exploitation occurs when the caregiver or the children of the abused mother, okay, um, they're the ones who are already taking the pension of their parents. They already have the control of the money of the elderly or of the parents. So economic expectation would also be noted if the elderly is now unable to pay the bills, all right, and has no knowledge of the finances. And most often, all right, the children would like forge the signature of the elderly, okay, just to get the pension or whatever money that the elderly is supposed to have. Okay, so priority nursing action, again, nurses, so safety for the elderly. Now, in the event that there's already pressure ulcers, so you have to assess and treat the wounds. Okay, ensure that the victim is removed from the threatening environment. Adhere to the mandatory reporting laws, again, for the children, CPS, okay, Child Protective Services, and for the elderly, we have your Adult Protective Services, okay, Adult Protective Services. Notify the caseworker, and as a nurse, you have to document the occurrence, finding, action taken, and the victim's response. Are we clear? Very common, what came out in my exam, nurses, by the way, would be the economic exploitation. Okay, because back then, when I took the NCLEX 2015 and up to the current one, we all follow the same test plan. Okay, so for next year of April, there's going to be a new test plan. So an added exam questions that the NCSBN um, recommended, which is the NCLEX Next Gen. So if you are now ready to schedule for your exam, if you are now ready to take the exam in Australia, because after passing the NCLEX in Australia, you will still have to undergo that OSCE, right? So please be mindful of those because children, pedia, clients, what else? And elderly are most of the favorite of your NCLEX. Okay, so another, we have your spousal abuse or your BWS, okay, your battered wife syndrome. Your battered wife syndrome, this is actually a cycle of violence, okay, a cycle in the sense that would undergo, you know, three phases. First is the tension phase. Okay, tension phase, or tension building phase. Let's say a couple um, had a little argument, or you went home late, and so the husband went home late, and then the wife asked, why are you late? And this kind of like the husband or the abuser feels like he's being like interrogated. So it can be also like a form of finances. Okay, so there are the abuser is kind of like being interrogated here. And then serious battering phase occur, especially if the abuser is already sick and tired of, let's say, the wife who is like somehow saying this and that, right? There is already a hitting in this phase. Now, because of that hitting, the abuser or the husband would somehow feel guilty. So, because of that guilt feeling, honeymoon phase takes in or sets in. So, this is the time that the abuser would, be sorry or apologetic. And to show that he is sincere of being apologetic, so the husband would now take the wife to an expensive dinner, give gifts that are lavish, luxury gifts, but it did not really address the problem. Now, this cycle of violence can actually, with the period of the violence, this actually shortens. So in the first year of being married, let's say they had three fights, okay, arguments. And because of that, repeated cycle, repeated violence, and sometimes, the abuser would think that you're supposed to feel sorry for your actions that caused me to be this or harsh to you. But because I've already given you gifts, I have already taken you to fancy dinner, I've already given you flowers and chocolates, but it seems that you did not learn your lesson, and here you are again interrogating me, okay, harassing me. And then here comes the tension building, the serious battery, and then the honeymoon phase. The problem here is that this cycle shortens. Now every month there had been a fight. Okay, so now, characteristics of the abuser nurses: they have impaired self-esteem, strong dependency needs, all right, narcissistic and suspicious. They also have a history of child abuse during childhood. Now, they perceive the victim as their property, and they believe that they are entitled to abuse them. Most especially if they have been giving them like gifts, lavish lifestyle, right? They now have the control over you, all right? Now, it's not easy to leave this abusive environment, okay? Now, most oftentimes, okay, the characteristics of the victim here, remember the dependent personality disorder. They cannot leave the abusive relationship because they feel so dependent to the husband or to the abuser. Now, they feel trapped, okay, dependent, helpless, and powerless. Okay, and they would always think that, oh, what would I do if would I leave this relationship? It's hard for me to start over again. And they may become depressed. All right, they have low self-esteem, and they oftentimes blame themselves for the violence. Okay, oh, I should not have acted that way, so that my husband will not um hit me or this and that. So they would have a self-pity or self-blame. Okay, so management, this is a serious problem, a serious case. So management includes, again, for the BWS, be non-judgmental nurses. Okay, be non-judgmental in the sense that you do not put the blame on the wife. I told you to leave your husband, but you're so hard-headed, this, that, and that, blah, 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 so on and so forth. Okay, have an empathic approach. All right, assist the victim. Our role here as a nurse is to assist the victim to develop self-protective and other solving problem abilities. All right, so you have to assess any suicidal potentials or suicidal ideations. Remember, these victims are often depressed. They feel trapped, and in order for them to escape, all right, they would commit suicide. All right, give them or give the victim list of resources such as what hotlines, safe house, and shelter. Okay, and take note, encourage the victim to develop a specific safety plan. And that safety plan includes in one bag, all right, in one bag, you have to put all your important belongings, including the child's favorite toy. Why do we have to include the child's favorite toy? Especially if you are, or if you have children already, you do not want to leave the relationship with your child, okay, to the father who is the abuser, okay, for their own safety, because otherwise, if you leave them together with your child, the abuse would now be directed to your children. All right. So when you develop a safety plan, as much as possible, you have to include your children. Okay. Important belongings could include, let's say, your documents to start your own life after, being in that abusive relationship, anything that would support the woman to stand on their own. All right. Now, for the purpose of this topic, BWS, or for the purpose of your NCLEX, very common that those who are abused, in the past are women. But I'm not telling that right now in the present times that men or husbands are not abused as well. Yes, abuse also happened in male or even in the boyfriend or even husband. There are also women who abuses the husband. Okay, in fact, there had been a news recently that the boyfriend of this famous influencer, that famous influencer, female influencer, killed, okay, the boyfriend, and they're still young. And because of that aggressive um like trait or characteristics, they feel or she feel entitled to abuse the boyfriend because this woman is giving, every time when they had a fight, the honeymoon phase, okay, she would give gifts to the boyfriend. So yeah, but again, for NCLEX purposes, who are the common victim? The female. Who are the abuser? The husband. Okay, so did be non-judgmental. Okay, are we clear, nurses? Okay,
Yes,
so
ma'am.
on to our electroconvulsive therapy or your ECT. Now, ECT is another form of treatment for your clients who are not responding to your antidepressants, okay, or your depressive or depressed or severely depressed clients who are not, responding to the treatment, such as what your antidepressants. They have taken several antidepressants already, but there is no response, okay, or there's no effect already. Now, manic client who is not responding to the medication, which is your lithium, okay, and schizophrenic client, especially with those catatonia, all right, or catatonic schizophrenic client, all right, those who hold bizarre posture for a longer period of time. Okay, ECT is recommended. Now, ECT, this is actually delivering a shock to the brain, okay, to somehow regulate the flow or the functioning of your brain, particularly in the neurotransmitter level. All right, it's like you are inducing shock in here. All right, inducing shock in your brain. And very important nursing consideration, nurses, prior to your ECT, you have to make sure that the consent is already signed by the client or in the health or by the healthcare proxy. Advise the client not to eat, okay, 4 hours prior to the ECT. Okay, NPO, not even drinking fluids, okay, because this predisposes the client for aspiration. This is somehow you are inducing shock or seizure to the client who are undergoing ECT. All right. Now, during during the procedure, or about before the procedure or the shock is delivered, okay, you have to attach the electroencephalographic and electrocardiographic electrodes. All right, you have to constantly monitor the vital signs, administer the oxygen via face mask, okay, place a mouth guard. All right, what else? Administer the prescribed medication. All right, so we have your short acting anesthetic. All right, so what are those short acting anesthetic? Okay, so we have your barbiturates. All right, barbiturates. Okay, barbiturates. Your short acting, okay, anesthetic, barbiturates. What else? We have your muscle relaxant, a muscle relaxant, which is your succinyl. Succinyl choline. Okay. This actually decreases, okay, the seizure episodes. Okay, this decreases the seizure episodes. What else? We have your atropine sulfate. Okay, your atropine sulfate, this actually decreases, okay, the decreases the lacrimation. All right, so this decreases the possibilities of aspiration. All right, atropine sulfate. So we have your barbiturates, your succinylcholine, and your atropine sulfate. Basically your atropine, this dries out. Okay, your like your anything with let's say lacrimation ducts. Okay, this decreases your risk for aspiration. All right, that is your atropine sulfate. Now, since you are inducing seizure in your electroconvulsive therapy, it's very important that post, okay, ECT, you have to reorient the client to, okay, time, surroundings once they are awakened. Now, you have to maintain at least 90% of oxygen saturation. All right, and assess for gag reflex before giving the fluids or food. All right, assess the gag reflex. And another thing, post ECT, you have to advise the client. All right, advise the client to no driving. Okay, no driving after ECT. Okay, they should be, or a family member should accompany the client. And what is also expected post ECT, all right, what is expected post ECT is that they would have a short-term memory loss. All right, it's expected that they would have a short-term memory loss post ECT. Okay, are we clear, nurses? Any one of you have seen a series? I forgot. Okay, this is a good example that Claire Danes, it was Claire Danes. Forgot the name of the series, but it's a very good series. It talks about I think she was an FBI in there, and the problem is that she's actually kind of like she has this bipolar problem, and in that she was under your ECT, electroconvulsive therapy. What else? We also have another series from Netflix. I don't know if you have seen the Hello Rage. I think that was the title of that series. So it was also seen in there. Okay, the electroconvulsive therapy for that series. Another movie that I can recommend to you, which is I highly recommend this movie to you so that you'll have an idea of the mind of your psychotic client or a client with seizure would be A Beautiful Mind. It's a true to life story. Okay, so he's a famous professor, a very, very intelligent professor, and sadly, he actually had, schizophrenia. What else? Another movie would be the movie of um, Leonardo DiCaprio, the movie of Shutter Island. It's really one of my favorite movies, Shutter Island. So you would see, okay, you can definitely relate to, okay, the person or the mind or an individual with psychosis or your schizophrenia. So if you have time, if you wanted to relax from study, you can definitely watch those movies, most especially The Beautiful Mind and Shutter Island. Yeah, of Leonardo DiCaprio. Okay, well, so much for that. Okay, let's now talk about the psychopharmacology. All right, so if anyone who here is struggling with um, the pharmacology side of the NCLEX or questions, I know it's hard to memorize these medication. You do not really have to memorize them, but I would say be familiar with those medications. Read those medications all the time, because you know being familiarized with those medication, definitely the mechanism of action, what these drugs are for, the side effects of these drugs, what to do, what to manage. Okay, so psychopharmacology, first let's talk about the drugs for your schizophrenia. Drugs for schizophrenia, we have your antipsychotic drugs. And your antipsychotic drugs, these are major tranquilizer. Okay, so we have two types. We have your typical and your atypical. Typical antipsychotics, these are the first psychotic drugs that has been developed in the past. Okay, however, these typical antipsychotic drugs predisposes or has more episodes of your side effects of your antipsychotic drug, which is your extrapyramidal side effects. Okay, so what are these typical antipsychotics? We have your haloperidol or your Haldol, your chlorpromazine or your Thorazine, and your thioridazine or your Melaril. Now, your haloperidol, all right, your haloperidol, this actually, can I just mention this one? Or if you want, any one of you writing, taking down notes as we
Yes,
go
ma'am.
along? Okay, anyone is writing. All right. So your haloperidol or your Haldol, this is actually the first developed antipsychotic drug. And among your chlorpromazine, tioridazine, this actually increases. Okay, this increases the EPSE. Okay, increases your extrapyramidal side effect, which we will identify later on. Now, side effect of this drug is that it can cause photosensitivity. So when the client is taking your haloperidol or your Haldol, you have to advise the client to wear long sleeves, avoid sun exposure, all right, wear SPF, okay, because these drugs causes photosensitivity, all right. What else? Your chlorpromazine or your thiorazine, okay? So this drug can actually, side effects of this drug, okay, side effects, this can actually cause hypotension. So if the client is taking your chlorpromazine or your thorazine rather, so you have to advise the client to, when they when they stand up, so from the bed, you have to advise them to sit down first, okay, on the bed, and then slowly rise up, rather than from bed to getting up, okay, automatically. So the more it predisposes them to have hypotension. All right. So another, the most like less episodes of EPSE, we have your atypical, all right, atypical antipsychotic drugs. So we have your clozapine, we have your olanzapine, we have your Seroquel or your Kitapin, and your ariprazole. Excuse me. Okay, so we have your atypical antipsychotic drugs. We have your clozapine, olanzapine, Seroquel, all right, ariprazole, and okay, to add, we have your okay, risperidone, risperidone, and or your risperidol. Okay. Risperidone or your risperidol, this is now actually the drug of choice for your antipsychotic drugs. Okay, this is the drug of choice. The DOC, this is the drug of choice. Now, take note, nurses, if the client is taking your risperidol or your risperidone, doctors may give this into, okay, either once a day, okay, they may prescribe this 2 times a day or a maximum of 3 times a day. All right, once a day, twice a day, or maximum 3 times a day regimen. All right, or in the course of the medication. Why? They should not go beyond 3 times, okay, for this drug. Why? It's because the client should maintain a therapeutic level, okay, therapeutic level of at least 4 to 8, okay, milligram per DL or per day. Because otherwise, if they go beyond 3 times a day, more than 8 milligrams, this can be toxic. All right. Now, for the reason as to why your risperidol or your risperidone is the drug of choice, because this can actually suppresses your tardive dyskinesia. Okay, are you familiar with your tardive dyskinesia? Okay. Your tardive dyskinesia is one of the extrapyramidal side effects of your antipsychotic drugs. Okay, wherein this is irreversible. All right, regardless if the client is recovered or the treatment for your schizophrenia or psychosis is effective, but because of those typical, okay, your haloperidol, haldol, they would have these episodes of lip smacking, tongue protrusion, or we call that your tardive dyskinesia. Now, because of your risperidone, risperidol, okay, this actually suppresses tardive dyskinesia. Okay, this suppresses tardive dyskinesia. And take note, nurses, okay, for your clients taking your clozapine, now adverse effects of these drugs is that this can actually cause your agranulocytosis. Okay, adverse effect, this drug causes agranulocytosis. Okay, what do you mean by agranulocytosis? The granules specifically of your WBC, okay, are all down. So this predisposes the clients to infection, okay, agranulocytosis. So if the client is taking your clozapine, it's very important that you have to educate the client to report any presence of fever, okay, and sore throat, because these are already indication that there is already infection, meaning to say your immune system is weak, okay, agranulocytosis. All right, so to monitor your CBC, okay, to monitor your WBC particularly, you have to advise the client to do CBC weekly. All right, do CBC weekly, and the type of CBC, it should be better with, differential count. Okay, differential count of your WBC. Okay, components of your WBC. We have your neutrophil, basophil, eosinophil, particularly your neutrophil, because this is the component of your WBC that fights against infection. All right. What else? Your olanzapine. So your olanzapine, okay, this typical, or sorry, this atypical drugs, okay, common side effect of this is that this can actually have your anticholinergic, okay, side effects. Okay, anticholinergic side effects includes, includes constipation. So the client here would be constipated while taking the olanzapine or your Zyprexa. All right, so these are the things that you have to take down. Please take down notes on your risperidone, risperidol. Again, risperidol, this is already the drug of choice. Okay, so let's try to identify what are those EPSE. Okay, what are those extra pyramidal side effects? So I have here, okay, pseudo-Parkinsonism. Okay, pseudo-Parkinsonism is that pseudo similar to the side effects or manifestation, rather, of your clients with Parkinson's disease. However, it's not completely as similar to the manifestations of your Parkinson's. So if the client is taking your atypical or your atypical antipsychotic, okay, they would have cogwheel rigidity, bradykinesia, and shuffled gait. Okay, similar to your clients with Parkinsonism. Now, we also have another here, a side effect, which is your akathisia, a feeling of restlessness or a feeling of having ants in the pants. All right. Acute dystonia. Okay, acute dystonia, this is your involuntary muscle spasm. Involuntary muscle spasm. Now, we also have your tardive dyskinesia. Again, tardive dyskinesia, this is irreversible. So regardless if you recovered already, you keep on having that lip smacking and tongue protrusion. And it's kind of like awkward, when you talk to somebody, when you keep on smacking your lips and protruding your tongue, right? So again, drug of choice to suppress your tardive dyskinesia would be your risperidone, risperidol. All right. And the most fatal effects of your antipsychotic drugs would be your neuroleptic malignant syndrome. Okay, your NMS. So this is actually fatal, your NMS. So it's very important that you have to educate the client or the family members if there's already increasing temperature. Okay, so if you notice increasing temperature, high grade fever, you have to withhold the drugs. Okay, withhold the next dose. Report that immediately to the doctor so that the doctor would give your dantrolene as the antidote. All right, as the antidote. Now take note, another serious effects of your antipsychotic drugs is your acute dystonia. All right, acute dystonia. Take note, these are involuntary muscle spasm. Now, this can actually have an effect, okay, or this can actually causes respiratory depression. Remember, our diaphragm is muscle, right? So involuntary muscle spasm, this can also cause a spasm in your diaphragm, which causes respiratory problems or depression. Okay. What else? There could also be laryngospasm. All right, laryngospasm in your acute dystonia. All right, laryngospasm. So another drugs, okay, psychopharmacology drugs, we have your drugs for depression. So we have three types, okay, of your antidepressants. We have your selective serotonin reuptake inhibitor. We have your selective serotonin reuptake inhibitor. So they would only increase the number of your serotonin. Okay, it's specifically targeting increasing the number of your serotonin. Remember, one of the cause for your depression is that you have low levels of serotonin, right? So your mood regulating neurotransmitter. So selective serotonin reuptake inhibitor. So what are these drugs? What are these SSRI? Okay, what are these SSRI? We have your Paxil. Okay, we have your Zoloft. Okay, and your Prozac. Okay, familiar with these drugs? Are you familiar? Are you familiar with these drugs? Anyone? Okay. SSRI, selective serotonin reuptake inhibitor. So, okay. Paxil should be administered with food. Okay. Should be administered or it should be given, okay, with food. Okay, Paxil. All right. Are you writing, nurses? Are you writing it down? Okay. Now we also have another drugs for antidepressant. Can I move on now? Okay. Your MAOIs, all right, your monoamine oxidase inhibitor. So remember yesterday I asked you what are those MAOIs, right? So these are your very common, known as your PAMANA, all right? So your Parnate, okay, Marplan, and your Nardil. Or you can term this as your Panama, okay, your Panama drugs, your Panama. So these are your Panama, okay, Parnate, Nardil, and your Marplan. All right, your Parnate, Nardil, Marplan. These are your MAOIs, okay, your monoamine oxidase inhibitor. We have to be very careful, nurses, when you're giving your MAOIs. Okay, you have to watch out for anti or no hypertensive crisis. Okay, you have to watch out for hypertensive crisis. So it's very important that when these clients are taking your Parnate, Nardil, Marplan, okay, they should avoid, okay, no tyramine rich food. Okay, otherwise if they are taking, okay, tyramine rich food and taking your Parnate, Nardil, Marplan, they can have hypertensive crisis. So can you give me an example of your tyramine rich food? What are those tyramine rich food?
Baked food.
I'm sorry?
Baked.
Baked food?
Yes.
Okay. So more of your smoke, okay, smoked food. All right, smoked food. What else? Or your grilled food, okay? Overripe fruits. All right, aged cheese. These are foods that are high in tyramine. Okay, what else? Your pickles are high in tyramine. Your pickles are high in tyramine. Now, another thing, you have to advise the client to no smoking. Okay, not just for your MAOIs, but also for any other antihypertensive or overall when you are in the course of your medication regimen. Okay, no smoking, no alcohol, okay, and do not no taking any other antidepressant. So you do not take any other antidepressant drugs. So if the doctor ordered you MAOI, so you have to take MAOI. All right. Another things that you have to avoid, um, this um, herbal medication, okay, which is your St. John's wort. Remember your St. John's wort? Do you remember this one? Okay, so that is for your antidepressants. Okay, so very important that you have to watch your, okay, hypertensive crisis. And to prevent that, you have to advise the client, you have to educate the client to avoid thiamine rich food. Okay, HC is very good, Amanda. Yes. Okay, please may you show the SSR slide. Okay, the SSR, this one it's already blank, but again, the SSRI, okay, these are not. Do not worry, nurses. Again, what are those SSRI? Janine was asking. SSRI, we have your Paxil, Zoloft, and your Prozac. Okay, I'll give this to you. Definitely, you'll have a copy of this one. All right. Now, for your Mawis, your Panama, Parnate, Nardil, and your Marplan. Last, okay, antidepressant drugs, we have your TCAs, your tricyclic antidepressants. Okay, so tricyclic, your TCA drugs. So these are your drugs. Okay, these are your Elavil, okay, Tofranil, okay, your Elavil, Tofranil, your Anafranil, those drugs that ends with IL or NIL, all right, or your Pamelor. Okay, so TCAs, just think of like names of a women, okay, because most of them are somewhat like, you know, names of a women. We have your Elavil, Tofranil, okay, Anafranil, and your Pamelor. All right, so Pamelor, and take note that these TCAs, okay, they are what? Okay, uh, okay, they are cardiotoxic. Okay, so you have to watch out for episodes of cardiac toxicity. Okay, so cardiotoxicity. Okay, toxicity. So it's very important that, okay, if the client is already having not anti-dysrhythmia, but dysrhythmia. So if the client is already having, okay, or cardiac dysrhythmia, so that is already an indication that the client taking your TCAs is already having cardiac toxic side effects. Okay, so you have to watch out for cardiotoxicity as evident by your cardiac dysrhythmias. Okay, cardiac dysrhythmias. I thought the trade names are not asked on NCLEX. Okay, so Elavil, this is your amitriptyline. Okay, no worries, Amanda. I will give to you the complete name of these drugs. Okay, you will have a copy. All right, so Elavil, this is your amitriptyline. Just 1 second. Okay, amitriptyline. Okay, your Tofranil, these are your, okay, imipramine. Your Anafranil, this is your clomipramine. And your Pamelor, this is your nortriptyline. So please take a photo of this one. All right. So watch out for cardiotoxicity as evident by cardiac dysrhythmias. All right. So TCAs, nice to know information, nurses. So this is actually one of the oldest antidepressants. All right, oldest antidepressants, and very important that you have to, okay, again, avoid giving with together. Okay, avoid giving together Mawis. All right. Again, what is the effectivity of these antidepressants? How long would its effectivity would take effect? What is the effectivity of these antidepressants? For how many weeks? How many weeks? 4 to 6 weeks. Very good. Okay. In some books, it is 2 to 4 weeks. Okay. But again, within that 4 weeks, usually there's already an improvement of the client's condition, most especially with their energy. That's the most crucial time that you have to monitor these clients, okay, depressed clients, because otherwise they now have a lot of energy to carry out their suicide attempt. Okay, so we also have your anxiolytics. Okay, we have your benzodiazepine and your non-benzodiazepine. So benzodiazepine, we have your alprazolam, diazepam, lorazepam. Okay, those drugs that ends with zolam and zepam. So non-benzodiazepine, we have your buspirone, buspar, and your zolpidem and your ambien. Now, side effect of these drugs, your anxiolytic side effects is that this causes your drowsiness. Okay, drowsiness. So therefore, since this drug causes drowsiness, you have to advise the client to avoid driving. All right, avoid operating heavy machineries. All right, and what else? Buspirone. Okay, the most recently discovered non-benzodiazepine. This is safe, okay, if the client is taking alcohol. Okay, there's no adverse effect. So if the client is taking alcohol while taking your buspirone, that's perfectly fine, okay? Because it does not have an interaction with your alcohol, okay? And drugs for your Alzheimer's, we have your donepezil or Aricept and your Tacrine or your Cognex. Okay, drugs for Alzheimer's. Okay, your donepezil or your, somebody's moving. Okay, donepezil and your Tacrine or your Cognex. Okay, so very important that you have to educate the client, okay, for those taking your Aricept, your elderly or even the caregivers or the children for your clients with Alzheimer's. Donepezil actually causes your easy bruising. Okay, so there's bruising tendencies. So it's very important that you have to advise the client to avoid constrictive clothing because this drug causes easy bruising. Okay, side effects would be bruising. All right. So your Tacrine, on the other hand, it's very important that you have to advise the client that this drug causes, okay, liver toxicity. Okay. This drug causes liver toxicity. So it's very important that you have to check, okay, your liver function test. You have to check for your SGT, SGPT, all right, your LDL. So liver function test is very important while the elderly is taking your Tacrine or Cognex. All right, so any questions, nurses? What dosage it is given, specifically with the dosage, CG, it's not very like, there's no indication. Depending, that would be the discretion of the doctor, but you have to take note on the effectivity. So again, 4 to 6 weeks before it takes its effectivity. And on the 4th week, you have to monitor for any episodes of increasing energy, because that's the time that, suicide may be successful, or suicide attempt may be successful. All right. So thank you so much, nurses. And if you do not have any questions, please remember this. Okay. Keep calm and remember that you'll pass your NCLEX. Okay. Just keep calm and remember to always believe,
Thank you, ma'am.
always manifest that you will pass your NCLEX. Okay. Any questions? Okay. So thank you so much, everyone, for attending, and I'll see you all on Monday. Okay, so I'll be with you by Monday.